so much for coming. I'm Debbie with the Wellness Committee, and I want to bring to you a wonderful provider that will give information that can change your lives and the lives of your loved ones, truly. This is Amy Blackmon. She is a PhD clinical psychologist who does screening for how your brain is working, the functional part of it, the part that makes a difference to our independence. And I asked Amy what's something that people might not know about her. And she told me she has both dogs and cats, but during the pandemic, she fostered 25 cats to give them a home. So that tells you a little bit about her heart right there. And what she does is neuropsych evaluations or testing. And that may be familiar to many of you. Some it may be fabulous, some it may be scary. But I'll share something personal. Hank and I both went through neuropsych evaluations, but we did it after we got into Westminster. We decided that way we failed it, we'd already be here, so we'd be okay. But we really did that because, like everything else in our health, from our feet to our eyes to every part of us, we want a baseline. Because when things happen, we want to see, are we dropping down 5%? Are we down 50%? What is going on as it relates to our baseline? And we feel so secure that we know where our baseline is, where we're strong, where we're weaker, and we know exactly where we started. So that's what Amy's going to talk to us about. And would you all silence your cell phones, please? I didn't silence mine. But let's give Amy a warm welcome.
Thank you so much, Debbie. It's so good to be with all of you today. And after the tour I got from Debbie at Westminster, I'm a big fan of Westminster as well. What a lovely, wonderful place. All right, so yes, as she mentioned, I'm here to talk about neuropsychological assessment, which can be scary and also can be a little fun, and certainly is illuminating for anybody who likes to learn about themselves. But we're going to talk about some of all of those things, and I want to encourage you to please ask questions even now if you want to start with questions, and we can do them at the end, but throughout, so don't feel like you need to wait if you have something pressing. All right, so this is a little about me. I did a bachelor's at Rice in Houston in psychology and French, a PhD at Yale in 2000, and a couple of master's degrees along the way before the PhD. And then I completed the American Psychological Association Division 40 training, which is the neuropsychology division, which included a pre-doctoral internship that was at the South Texas Veterans Healthcare Center, and a postdoctoral fellowship at a post-acute brain injury facility in Dripping Springs. I am and have been a licensed psychologist in the Austin area for over 20 years. I have done different things in my career, including teaching medical residents and graduate students at the University of Texas, Austin, supervising other psychologists who needed some training. And I had hospital privileges for 15 years, although now I'm very happily doing only evaluations and only for adults in my Northwest Austin office, and this is my Northwest Austin office. I love to go there every day. Here's how you can reach me, my email and website if you're interested. Also, there will be a handout at the end that have those things on it, so don't feel obligated to get that now. So the first thing I want to talk about is why would anybody come for neuropsychological assessment? And there are lots of good reasons to do it. The first is when there's really a known cognitive problem or neurological problem, like a stroke or a brain injury. We had a lot of folks after COVID coming in and saying, I think I have long COVID and I've got cognitive symptoms. What can you tell me about that? Or other infections. Usually that's very obvious to the patient or client and to their family and their medical providers, and they come in to see what has been the result on their cognitive functioning of that obvious medical concern. And the next is a little harder to know, and that is progressive changes, subtle changes over time that all of us experience as adults. Those changes happen naturally with age. Some of them are very normal. Memory, for example, starts to decline around age 45 and gets more obvious as we get older. So then people are left wondering, what is going on? Is this a progressive aging and just normal aging, or is it something above and beyond that? And that brings them in for neuropsychological assessment. And this can be noticed by you or by a loved one or by your doctor. Any of the above could bring you to me. Other reasons why people might seek neuropsychological assessment are because they went and saw their doctor. This could be a primary care doctor, could be a psychiatrist or a neurologist, and they did what's called a mental status test. This is a brief, quick sketch of your cognitive ability, 5 minutes. They have you do things like draw a clock, count backwards by 7s or 3s, spell some words backwards, and so on. Kind of tough things, and there's a little memory portion to it. For folks who don't score where they want you, they could send you for neuropsychological assessment. You might be having a bad day. There might be another health reason or other reasons that could affect your cognitive abilities, and I'll talk more about those. So it could be a false positive that brings you in, but the neuropsychological assessment can tell you more about how you're actually doing, because it's a much expanded version of that mental status test. People also come in because they have a family history, a sibling, a parent, more than one relative maybe, and they want to know, is the same thing happening to them? And that can be kind of scary when they come in. I've had a lot of folks come in for that reason who ended up without a diagnosis and were doing well. But that does bring people in. And finally, like Debbie mentioned, it's a really good idea to get a baseline. It's not required. Your insurance company is not going to ask you to do it, like they might ask you or want you to get labs every year. But for those who are wanting to know about the different body systems, including cognitive abilities and brain functioning, a neuropsych baseline can be useful, and it can sometimes be covered by insurance. So those are the whys, but what can it do? How can it be helpful? I want to talk about that a little. The first is the obvious, it's peace of mind. For many folks who come in worried, maybe worried about their family members and as a result about themselves, they do learn that they're fine. And they get a baseline, and that will help them in the event they have some decline that they notice in the future. Another is for diagnostic clarity. I spoke about the normal aging process, and so the main benefit of the tests, in my view, is that they all have normative data, and I can compare the results of an assessment to that normative sample of age and education-matched people, so that we can see if that normal aging kind of curve is being followed, or if there's something else that's suggested by the data. And different kinds of cognitive diagnoses have different kind of pattern profiles in the data. So the stats are important. It can also be helpful, this is coming up more and more, I find, that folks are wanting to know about their their genetic load. We can talk about environmental causes, and I do in the course of an assessment, because those are often modifiable or fixable. But the genetic part is not really, we can't do anything about that. But we might want to know for future generations what that genetic risk is, and diagnostic testing can lead people into genetic testing sometimes. It's optional, of course. And finally, just planning for the future. If there's a diagnosis and it's very mild, and you weren't sure, and you came in and you got diagnosed with something very mild, there might be a lot of really excellent choices you could make to plan for the future and also preserve a great quality of life, which is the main thing I want for my clients. So what happens? How does it go? Well, first, you get a referral. The referral could be from you. You might decide you want to do it, and you refer yourself, and that is perfectly fine. You could also, the most common, is to get a referral from a neurologist. They like to request neuropsychological testing on a regular basis. Could also be an internal medicine or family doctor or a psychiatrist. They would send over, or if you were to refer yourself, you would send me medical records to review. Neurologists are always great about this. They send a lot of records, and I review them so I can know about your medical history and what you're concerned about now before we ever meet. Next, I send out my own forms, questionnaires, so consent forms so you know what you're getting into, although you all will know by the end of this talk what you would be getting into. Your medical history, and also a questionnaire to be done by somebody who knows you well, because it's always good to get multiple perspectives about what is happening, if anything. The next step is an interview, and I prefer to do this with the client and somebody who knows them well, although that's not required. Many people don't have a person to bring or don't want to bring somebody, and that's their choice. And finally, the testing, which takes a few hours, and we do this in my Northwest Austin office. We take breaks. I'm not interested in torturing anyone or myself, so we definitely take breaks to get through it with just as much peace and calm as possible. There are occasions where folks can't finish it all in one go and need to go home and come back another day, and that is also perfectly fine. Sometimes I'll send people home when I notice they're getting tired and it seems like they're slowing down. But more often, they'll tell me, I don't think I can do my best anymore. And I really want that, because to speak up and say that means that we can stop and we can complete when you're fresh again. And that way we'll get valid test results and we won't be measuring fatigue, which I don't want to do. So the assessment's all done. What happens next is I spend a lot of time with the numbers. I score all the test results, and I do the statistical analysis that I spoke about before, and I write a report. The report is written for the referring person, for the neurologist, who also is very likely getting other diagnostics, blood tests, brain imaging, etc. However, it should be understandable to you. And so if it's not, there are ways to get understanding about what's written there. A lot of it is, but some of it's not. And then we do a feedback session. I want to talk more about feedback specifically. Who gives you the feedback? That could be the referring physician. Neurologists like to do this. They like to give the feedback, and that's fine with me. I like to do it too. But if they want to do it, it's okay. They do, like I said, have access to more information than I do. The blood tests, the brain imaging, etc. And so it makes sense for a neurologist to be at the hub of a person's cognitive care. I'm a spoke on that wheel. I'm a big spoke, but I'm not the only thing, and the neurologist is at the center typically. But for some, they want the results to be given by me, and I'm happy to do that. If a psychiatrist or an internal medicine doctor, family doctor refers, or if a person refers themselves, I more often give that feedback because there's not a doctor or other person who is choosing to give it. And then, what could the findings be? That's what happens in the feedback, is we talk about findings and we talk about recommendations if applicable. The first possibility, and I do see this frequently, is that there is no cognitive diagnosis. Maybe there's another diagnosis, like depression or anxiety, maybe there's not. Whatever the findings are, we talk about them. Every human has cognitive strengths and challenges or weaknesses, and we talk about that because you've learned about it, so let's enrich. But sometimes there's no diagnosis to go along with that, and people like that. And then there are the big two cognitive diagnoses, mild cognitive impairment and dementia. Mild cognitive impairment being a milder form of cognitive change that may or may not progress to dementia. There are lots of reasons for mild cognitive impairment, and sometimes it does eventually become dementia, but not always. And so it's important for us to look at not only what areas of cognition are affected, but also what might be the possible causes. Because when there are causes or suspected causes for mild cognitive impairment that are reversible, we want to pay attention to that. Okay. Finally, dementia can be diagnosed. Typically, folks who come to see me have what we would call pretty mild dementia. If they don't know, it's quite mild. I don't know about you, but I think most people, when they think about dementia, they think it's quite obvious because what they have seen of people who are diagnosed with dementia is something that they can really tell is dementia. But there are a lot of folks walking around with dementia who you couldn't readily identify. So sometimes those milder cases get diagnosed in neuropsych assessment. So this is some of the good news that can come from an evaluation, and that is possible causes that can be improved with behavioral changes or medical interventions. That's not to say that these things are easy, but they're possible, and I think they're worth knowing about. The first one that we might identify is that there's either a sleep disorder that's not being adequately treated, or there's a suspected sleep disorder based on perhaps what your partner has observed and what I've asked about in the interview. Nobody really wants to be diagnosed with sleep apnea, which is the big one, because sometimes the treatment is hard to tolerate, but there are more and more treatments available, even for folks who are kind of resistant to a CPAP machine or a BiPAP. And it does protect the brain health, so we talk about that. The next kind of mini lecture that I give, and I always apologize, but I have to, is about alcohol use. And now CDC is recommending really that we don't drink at all. They want us to have one serving a week, which for most who drink is not anything really to speak of. And that's mainly for cancer prevention, but from my point of view, it's also for brain health. And so we talk about that, and if there is enough alcohol being consumed that could be affecting cognitive status, we absolutely discuss that. Medication side effects as well. We all know that things like narcotics can affect your cognitive abilities, but there are, of course, a lot of other medications that can too. I would never suggest that somebody get off a medication that they need, like a statin or a reflux med or antihistamine, but I do recommend they speak to their doctors about it and how it might be affecting cognitive abilities. Pain is another possible cause of cognitive change, in that folks who are experiencing pain, it's a drain on the attention span. And whenever your attention is taken away from your day-to-day life to something like pain or depression and anxiety down below, it can affect the attention span in a way that also affects memory. If you're having a hard time paying attention, you're going to have a hard time encoding what's going on around you and be less likely to remember it later. So that might be called out. I always look at sensory needs like vision and hearing, because if you can't see or hear what we're doing, your test results are also not going to be valid. So we really do want to uncover that right at the beginning, and we do. And then finally, vascular disease. The prevailing wisdom, people always ask, what can I do? Can I do Sudoku? Can I do crossword puzzles? Will it help? And it won't hurt. But the prevailing wisdom is that whatever is good for your heart is what's good for your brain. And so we really do have to look at any symptoms or signs or risk factors for heart disease that can also be affecting the brain. Yes?
On pain, do you distinguish between mental pain and physical pain?
I do. I ask about both. I do screens of depression and anxiety, and if somebody comes and says to me, for example, hey, I know I have post-traumatic stress disorder, I will query in more detail about that thing, mainly for my purpose to see to what degree could that be affecting his attention span and therefore the memory. But physical pain too, and so I ask about that separately. They're both important. Yeah. Good question. And then there are possible causes that cannot necessarily be reversed, but should be addressed or managed medically by a neurologist typically, and those include progressive cognitive decline. The most common source of this is Alzheimer's, frontotemporal disease, which looks different from how an Alzheimer's type presentation looks. Parkinson's related decline, again, looks a little different, more similar to frontotemporal than to Alzheimer's, but Parkinson's is a funny one and it can look a lot of different ways. And then falls and traumatic brain injury, stroke and seizures, of course. So what do we do with all of that? What good does it do and how does it help? I think mainly in the form of recommendations. And we do spend a lot of time on this in feedback. Most of our time is spent on this. And it includes referrals. I'm happy to give specific names of favorites. Neurology is often, again, at the hub, so the most important. And if there's a cognitive diagnosis, I should say. If there's not, if there's a psychiatric diagnosis, we want to put psychiatry at the hub of the care. I'm really happy with what's happening in Austin with neurologists right now. There are a lot of new providers that have been hired. I think we lost a lot of them during the pandemic. We had a lot of folks retire. And we're getting now some wonderful new doctors, and I'm always happy to pass on those names. Also psychiatrists. There are often needs for things like speech therapy, if there's changes in speech. Yes, please.
Can you differentiate between a neurological diagnosis and a psychiatric diagnosis?
I heard, she asked, could I differentiate between a neurological and a psychiatric diagnosis? And yes. So a neurological diagnosis is something affecting your cognitive functioning, attention, learning, memory, language, fine motor skills, and so on. What the brain does, okay? A psychiatric diagnosis would be something you would see a psychologist or a psychiatrist for. Depression, anxiety, post-traumatic stress disorder, obsessive compulsive disorder, things like this, mental health concerns, okay? All right, other services that might be recommended are speech, occupational, and physical therapy, depending on what kinds of challenges are coming up in interview and in test results. Cognitive rehabilitation, which can be done particularly with a mild cognitive impairment diagnosis, and psychotherapy if needed. Resources that I routinely offer are book titles for client and their family members about all kinds of things, local nonprofit names and resources that they offer, as well as clinical trials if that's appropriate for the client. I do also recommend ways to reduce risks and improve quality of life. And those include a driving evaluation. I will tell you that this is a very common and very scary recommendation that people receive, but I think it's very important. I would definitely recommend my family member do it for any who receive a cognitive diagnosis, because let's say you are a perfectly good driver, and even my test results show that it looks like you could drive perfectly well. But you have received a diagnosis of mild cognitive impairment, let's say, or even mild dementia, and you feel like you can and should continue to drive. I say, yes, we want you to do that. And go to St. David's Adaptive Driving Program. Don't go to the DMV and ask for a driving test. You take the test there, and they either pass you or fail you. They either let you keep your driver's license without recommendations about what's safe, or they take it away. This isn't really that helpful in terms of preserving independence. But St. David's is quite different. And they will discover through the course of a much more comprehensive evaluation about circumstances in which it is and is not safe to drive. And they'll tell you, you're having trouble managing visual glare. You should avoid driving at night. They might say that you have memory concerns, so you want to stay within a 5-mile radius of your home. You want to learn you're having trouble with visual spatial problem solving, so we want to be sure that you are very comfortable with GPS and so on. So it's always important to me and to everybody who comes to see me to remain as independent as possible, and that's the goal. But when you get that evaluation from the experts and they say in their results that it's safe to drive, that is a legal safeguard in the event that there's an accident in the future. Let's say you have one, it happens to all of us, it's not your fault, but the person in the other car subpoenas your medical records and they discover that you have a cognitive diagnosis. This type of recommendations, saves you from some litigation. So I always like for folks to do it, even if they don't need it sometimes, okay? Don't think they need it. I might also make recommendations about daily living skills, and so people want to have control over all of that, and I want them to. I want them to keep working on their finances and keep working on their medication management and making their doctor's appointments. And sometimes I'll recommend some supervision, at least on a periodic basis, to be sure that details are not being missed. And I give safety strategies to folks to remain independent as long as possible. Other behaviors that we address in recommendations are all the usual foundational health behaviors that we all know we should do, and sometimes we're better at some of them than others, like good nutrition and exercise and sleep, maintaining hydrated, keeping stress low, and making sure that substance use is under good control. Privacy is a common concern that people bring to me, and I want to address that directly. It is important to me to keep your information private, and it is the law. So let's just imagine that you come for an evaluation, you're using insurance. HIPAA has a lot of rules for me that I take very seriously. I'm not interested in losing my license. But your insurance company, of course, does have access to your records if they want them. I will tell you that in over 20 years of practice, an insurance company has requested a batch of records once. And they should do that every so often to make sure the provider is doing what they're supposed to be doing. It's not common, but they can, whenever they want, request your medical records. And you should be told by the provider if that happens. But we don't ever truly have privacy from medical insurance when we use it. But with that, I will say that I only send your report to the referral source, and I like to send it to you. Once you receive feedback, which is standard of care, learn what the results mean and say, and then have it so that you can share it with whomever you might want in the future. It can go to somebody who has power of attorney or guardianship if that's applicable for you, but otherwise I can't send it to anyone unless you request in writing that I do so. And some folks do, I'll mention, prefer not to have their medical insurance know their test results, and they come in and refer themselves, and they go through the evaluation and pay privately, and I don't file insurance, and then the insurance does not have access to those results. I'm not on any kind of a digital medical record that's uploaded anywhere unless and that wouldn't happen unless you gave the results to a doctor who does have that kind of medical record and they put it on. So you can be your own gatekeeper about where that information goes, if that's what you prefer. What questions can I answer? Yes, please. Could you say that again, please?
How do you enroll in the same thing that's driving evaluation?
Oh, you can just call St. David's Adaptive Driving Program. You can find it online. You do need a doctor's prescription for that. And last I heard, it was a pretty long waiting list to get one, 4 to 6 weeks. So I always like for folks, when they think they might want one, to go ahead and get that process started because it's lengthy, just to get in the door. We're very lucky to have them here in Austin. It's a service that many larger cities don't even have. So it's a very nice thing that we have. Yes, there's one back there. Debbie behind you.
How long does an evaluation like that good for?
How long is it good for? When would it expire? Well, that's a tricky and good question. I don't think it necessarily expires. So what I would say though is for those who are wondering should they have another evaluation to make sure it's up to date and current, that I had this question before we started actually, that I don't recommend an annual neuropsych. It's lengthy. It's not the most fun you'll ever have. It can be expensive and time consuming. But that what I recommend is that when you or your loved ones are noticing changes, if you've had a neuropsych eval and now you feel like you're in a different boat, it's a good time to come back. And that could be 1 year and it could be 6 years or longer. Mm-hmm. Yes, sir.
How long does a neuropsych evaluation take?
That's a good question. It's how long does a neuropsych evaluation take? And I'll tell you that it varies. Everybody's a little different in terms of how long they take with test taking. And with the questionnaires and the process before you ever get in the door. If you're a person who is detail-oriented and cautious, it could take several more hours. But typically, I'd say that the pre-appointment questionnaires take about 20-30 minutes. The interview takes about an hour, and the testing itself takes about 3 hours. Yes, in the back.
I've been diagnosed with Parkinson's, and about 6 weeks ago, I went in for a neuro assessment. The test lasted about 3.5 hours. I was never exactly sure why I was undergoing that test, other than the fact that my doctor, Dr. Eric Kraus, said, take this test, and then we'll evaluate you to see whether or not you're a candidate for deep brain stimulation. There are other things I have to do, but that was the very first thing he would have done. What was I doing at that test? Exactly what was he looking for in terms of results?
It is a little hard for me to answer that, not having access to your medical history, but I think it's a good idea when you go into a neuropsych eval for the first question from the provider to be, do you know why you're here? Do you understand what we're going to do today? If not, let's talk about it. So I wish that had happened for you. If you are a candidate or are wanting to consider deep brain stimulation, that evaluation is necessary prior to deep brain stimulation. They want to know specifically about your memory and also, are you experiencing depression? So those are evaluations I do, and those are the two main things we're looking for there. But in order to look at memory, it is best practices to also look at everything else that a brain does, the things I was talking about before: attention, learning, receptive and expressive language, motor skills, and so on. Did that answer your question? I think that might be the best I can do, given what I know about you. Sorry that. Okay. Yeah.
Are your services covered by Medicare?
Yes. I take regular Medicare, and some other providers take Medicare managed plans. I do not. Medicare always pays their portion, 80%, and the secondaries typically pay the remaining 20%, but that pattern of payment follows whatever you're used to with your Medicare and your secondary, because this is a medical procedure. So there should not be unexpected charges, and I do accept the Medicare rates, so there's nothing above and beyond what Medicare and the secondary is supposed to pay. Mm-hmm. Yes?
I asked this question about 4 years ago, and I'm curious. I've been here 6. I'm curious what your background is on it. I used to take students to Europe to learn foreign languages, and I would take the classes as well. And one of the things I discovered along the way from someone who was studying this was the opinion that after the age of 10, you store the language in a different part of the brain, and it has a more difficult recall. And I wondered if you'd ever studied the acquisition of language, because one of the things as you get older that they recommend is learning new languages. But it sounds like you're going to be somewhat at a disadvantage.
That's not my area of study. However, I have studied acquisition of language in general to some degree, and I don't know that language acquisition is actually stored in a different part of the brain. I think that's I couldn't support that answer necessarily. But it is more difficult, of course, to learn a new language once a person is older. I would not say that it's not worth it. I think it absolutely is. Just like anything that anybody wants to do for edification and self-improvement, should be done for enjoyment and the love of it, and also because it's good for the brain.
Any other questions?
Up here in the front. Now I can probably hear you.
We all go through, before we are admitted into Westminster, a basic test. Is your basic test the same, or is it what you?
Mine would very likely be much more complex,
Okay.
much more in-depth. I would imagine that the basic tests might be more similar to the mental status test that I mentioned earlier that you might do as a screener with a neurologist or a primary care doctor. I don't know for sure what they do here, though. Do you know, Debbie?
This is much more, yeah, what you do is much more detailed. No one spends 3+ hours on answering those questions with a general physician.
And they likely wouldn't be needed.
And they pick up all kinds of things you wouldn't expect. I was telling Amy at the beginning that when Hank and I had our testing, I was so relieved we did okay. And then Dr. Bertelson, who did the testing, he called me, he said, Debbie, you did okay, but what's wrong with your eyes? I had failed to tell him I had macular degeneration, and the cognitive test picked up on the fact that I couldn't track the way normal eyes do. And I thought that was fascinating, that just from a standardized test that I actually took on an iPad picked up on that. So, it is important to give a full history, what your vision is, what your hearing is, all of it, because your brain is the control center for everything. And I was so impressed that the test would pick up something that I inadvertently failed to share, and how sensitive it is. It's wonderful to have that.
And for us, it gave us a baseline.
Yes, you missed the first part, Hank. We talked a lot about baseline. So thank you. Yes, I hope everyone here will go in, through whatever route, either directly or through your physician, and go ahead and get a baseline. It's comforting to know where you stand. So are there other questions? Oh, good.
I just wondered what you meant by a baseline.
A baseline is like, go ahead
I
and
can
explain.
take that one. Yeah, a baseline is when you don't really suspect that there is a cognitive problem, but you want to know how are you functioning right now. They do it for athletes now, football players and soccer players, because of the risk of concussion. And they want to know at the beginning of the season, how are they doing cognitively? So that if there's an event later, an illness, an injury, some other reason why we suspect that cognitive changes have occurred, you can compare apples to apples from point A to point B.
Mayo Clinic has a program, a course, for people who have mild cognitive impairment, and it requires a residency, and you have to have a partner. But it's very beneficial. We've done it.
Oh, wonderful. Thank you for sharing that. University of Texas Austin has also had mild cognitive impairment research and programs. They have it on and off, though. A place like Mayo will have it more of the time. Wonderful. There's one in the back, Debbie, one behind you.
What's the difference really between mild cognitive and dementia?
The difference is the severity of the symptoms. So there are kind of two big ways that these are measured, and one is in activities of daily living. I actually have a battery of tests of activities of daily living, making change, following directions with a microwave, and so on. So those activities of daily living are measured, and also just the pure cognitive skills like attention, learning, memory, and so on. We would need to see impairment in both of those areas in order for, as compared to the age and education match sample, in order for a dementia diagnosis to be given. But when there's just one, usually it's in the pure cognitive areas, attention, learning, memory, but the daily living skills are still intact, then a mild cognitive impairment diagnosis can be given.
Great questions. Thank you so much. We really appreciate your time and your expertise, and let's give Amy a big thank you.
Thank you so much for having me. I know that sometimes the questions are sensitive, and I'm going to stick around for a few minutes if anybody has anything they just want to ask me separately.